All right, I think we can likely go ahead and get started. Welcome everyone to Geriatric Medicine Grand Rounds. Today we have a fantastic speaker talking about a topic that comes up very often in all of our clinical practices. Dr. Clifford Hume is a associate professor of otolaryngology, head and neck surgery, and he is a physician scientist with a research interest in developing new therapies for hearing loss in particular. And I'm just so grateful that you've come to speak to us today.
Thanks for inviting me. So I'm going to talk a little bit today about dizziness and vertigo from the perspective of an otolaryngologist, and I'm sure you all see many patients with these problems. And just so you know, I'm based both at the university and also at the VA. So if any questions come up about shared patients, whatever, I'm always happy to chat with you. And we have similar kind of setups in terms of evaluation at both locations. So kind of starting off really with some of the key points that I want to bring up. I'm just trying to move this Zoom thing out of my window. It's right over my slide. The dizziness is not really a necessary consequence of normal aging, even though it's very common, and it can come from many different sources. And whether those are central related to central nervous system dysfunction, or they're peripheral from the vestibular system, visual or somatosensory, and then compounded by other effects like muscle weakness and arthritis. And then of course, there are always patients that have some dizziness related to anxiety or cognitive changes. But the encouraging thing is that with a fairly focused physical exam and a detailed history, we can usually arrive at a definitive diagnosis and determine if there are certain risks that we need to be aware to, be able to share with the patient, and also direct the appropriate treatment. And in some cases, as I'll kind of get to at the end, we do have some very specific balance testing we can do in our laboratory to try to assess the degree of dysfunction of the different pathways, whether they're central or peripheral, and then help arrive at a more definitive course of treatment. So what I'm going to do to start off is really talk a little bit about the impact of dizziness and kind of review a little bit how the vestibular system works, and then a fairly standardized approach that I think is very helpful to think about dizziness instead of sort of diving in and wondering where to start. I think it can be very helpful to use a systematic approach. We'll talk about some of the more common causes of dizziness that we see in the general population and in the elderly, and then where to go next if you're kind of stumped with what your evaluation is and your treatment, and kind of what some of the resources might be. So dizziness is incredibly common. It's about 15% of primary care visits overall, just in the general population. And the diversity of the diagnoses that can cause that dizziness is very wide also. So they can be peripheral, vestibular in origin, which the most common is probably benign paroxysmal positional vertigo, or BPPV, but other etiologies as well. Certainly cardiovascular disease related to arrhythmias and hypotension and so forth, and then neurologic disease with TIAs and strokes, psychogenic causes, and then of course there are many patients who it's not really clear during their primary care visits what the actual etiology is. But the effect of dizziness really isn't the same across all ages. So if we look just in a community population, the community prevalence is maybe only about 20% in individuals that are over the age of 60, but that goes all the way up to about 50% in individuals over the age of 85. But in fact, many of these individuals are never evaluated in the medical community. So there are many people in the community who have dizziness symptoms that are never completely evaluated. So what's encouraging is that majority of these causes are probably benign in the sense that they may not be life-threatening, but it doesn't mean they don't have a severe impact, because they lead to frequent visits to their physician. They can lose work time. They don't participate in activities they might otherwise participate in. They can cause gait impairments, which then lead to things like falls, hip and wrist fractures. And even just having dizziness leads to a fear of falling, which is also a risk factor for falling. So it can sort of start a whole cascade of events that can be a problem with the individual, especially in the elderly. And there's sort of an intriguing link that's becoming more understood in the last few years, that there may be actually a link between loss of vestibular function and changes in cognition. So we don't really understand exactly how that works yet, but it's kind of an intriguing finding, just like the link between hearing loss and cognitive changes. So one of the issues we have with our patients is trying to understand what they actually are experiencing. So what do we mean by dizziness when a patient says they're dizzy or faint, lightheaded, spinning, foggy feeling, or marshmallow brain, or they have all different kinds of descriptions for how they may be experiencing their symptoms. And how do we try to put that in a way that we can communicate to other people or find a way to arrive at a more definitive diagnosis for what's going on? So I think it's useful to have sort of a standardized vocabulary. And these are some consensus definitions of vestibular type symptoms that was brought together by the International Classification of Vestibular Disorders, which is a group that's out of the Barani Society. And using those definitions, dizziness is really considered a spatial disorientation, but without a sense of motion. Vertigo is a sense of motion, but there is no motion occurring. So it's a sort of a hallucination of motion, or sometimes that self-motion may just be distorted during normal movement. So that's sort of a variation of that. Whereas unsteadiness is unstable. It's not related to a sense of motion. It's really to a sense of being unstable on your feet or unstable in your positioning, a disorientation in space. And really it's similar to what we would call disequilibrium or imbalance. And those are sort of distinct from some other sort of group of symptoms like presyncope, which is the perception that they might lose consciousness or feel faint, or syncope where they actually do lose consciousness, but obviously they have full recovery. It's a relatively short duration, but that fainting attack is associated with a loss of postural control and falling. We're going to focus mostly on the ones that I have on the left side of the panel. And each one of these sort of descriptions of dizziness that a patient might use, we might assign to them, they can all occur whether it's in peripheral, central, or combined vestibular disorders. And so really the goal of diagnosis is try to stratify the risk for complications related to what the origin is and find a treatment plan, but also to help the patient understand what it is they're going through, what the prognosis is going forward. So if we look in a specialized dizziness clinic, so this is not the general population, but individuals seen in the dizziness clinic, you can see there's a really wide range of diagnoses. And the ones that are in red here are central diagnoses, which would be related to either a stroke or migraine or TIAs and so forth. And you can see that's about 25% even in a specialized dizziness clinic. But the rest of the etiologies is really quite widespread. And the most common one is benign paroxysmal positional vertigo, or BPPV. So I think that this is actually a population in Germany, but it looks very similar to what we see in our clinics here in Seattle. And this sort of distribution of diagnoses is not the same across ages. And this is important, especially when dealing with the elderly, because some things are much more common in younger people. So again, this is in a similar population in Germany again, but I think it's helpful to look at. And the abbreviations down here, this is bilateral vestibular hypofunction, central vertigo, BPPV, unilateral vestibular hypofunction. This is persistent postural perceptual dizziness, Meniere's disease, vestibular migraine, vestibular paroxysmia, and this is sort of unknown other causes. So what's interesting to look at is in individuals less than 40, you can see some of the really common causes are vestibular migraine and persistent postural perceptual dizziness, or 3PD. Whereas if you look in the older population, those are much less common, but bilateral vestibular hypofunction is quite common. BPPV is even more common, but there are also, again, other peripheral vestibular and central disorders that tend to cause more problems in the elderly. So when we think about vestibular function and the vestibular system, really it's a coordinated set of pathways that stabilize vision. They may help maintain posture and head position and balance. And that includes the inner ear and labyrinthine function, the visual system, and proprioception, which can affect both proprioception through the limbs, but also control of posture, and how that all these sensory systems are integrated by the central nervous system. So one simplified way that I think is helpful to think about how the vestibular system works is as a three-legged stool, where each one of the legs of the stool is one of the sensory systems that we rely on primarily for sense of balance, and your brain is kind of the coordinating center. So when people are having unsteadiness or dizziness, they may have a problem with one of the limbs or multiple legs of the stool, or they may have a problem with how the brain is sort of stabilizing these functions together, or they may have problems with all of them. And really, they're trying to help sort that out, can direct the type of treatment that we use. If we look at the vestibular system and the peripheral vestibular system and the labyrinth, it's helpful to think about the different components and how they're oriented inside of the head. So this is the right labyrinth, and you can see it oriented relative to the head that's kind of shadowed in the background here. And we have the three semicircular canals, so the superior semicircular canal, the posterior semicircular canal, and the lateral canal, which are the ampullary organs. And then we have the otolithic organs that have the otoconia, which are the utricle and the saccule. The utricle is oriented, and we'll kind of look at this a little bit later, but it's oriented mostly horizontally, whereas the saccule is oriented mostly vertically. And so the semicircular canals detect a rotational movement, whereas utricle and saccule detect acceleration either due to gravity or motion. And so it's the combination of the signals from these 5 balance organs in each ear that end up sending a signal to the central vestibular pathways. And we'll come back to why some of this orientation of the inner ear is important, related to some of the tests we use, but also how people can trigger symptoms. If we look inside those sensory organs, inside the crista of the semicircular canals, we have the sensory hair cells and the nerves that are going to the hair cells. And there's an overlying what's called a cupula, which is kind of a gelatinous matrix. So when fluid moves inside the semicircular canal, it displaces the cupula, it bends the stereocilia on the hair cells, and that triggers a change in the response properties of the nerve fibers from the ampulla. Whereas in the otolithic organs, similar situation where they're the hair cells and the fibers, but in this gelatinous matrix over the otoconial, over the otolithic organs, there are calcium carbonate crystals, or otoliths, which are stuck to this matrix. And when there's any kind of acceleration, there's a shear force which causes this to lag behind and bends the stereocilia, again, triggering responses from the auditory nerve, or from the vestibular nerve, sorry. So coming back to the planes that the organs are organized, if you think about how they are relative to the head, the horizontal canal is actually not horizontal. So it's oriented at about 30 degrees off of horizontal, so it's angled upwards. And that's the same plane essentially as the utricle. And the anterior canal, or superior semicircular canal, is oriented at about 45 degrees towards the front, and 90 degrees to that is the posterior canal. And the reason this is important is that individual canals are not oriented in the same plane that we normally think of anterior, posterior, and lateral. So that, and remember that how the canals work is that the axis of stimulation from each individual canal has to match the anatomic axis of the superior canal that generates the response. So that means that if you tilt your head forward, you're not just stimulating one canal, you're stimulating multiple canals. So the anterior and posterior canals on both sides. So that becomes important when we're trying to sort of untangle different types of abnormal eye movements like nystagmus. And in a case of an acute vestibular injury, where there's a loss of function of one vestibular nerve, then the tendency for the eye movements is going to be going towards the weaker ear. So if we look at the hair cells again, and this would be a kind of a generalization for the hair cells that are in either the ampullary organs or in the otolithic organs, we have 2 different kinds of hair cells, the regular and irregular, or type 1 and type 2 hair cells. And the types of responses they have are different, in the sense that some have a static response that's modulated by movement, whereas some have a more erratic response that's triggered by movement. So the way they respond can sometimes change, again, the way that the signals are transmitted to the higher vestibular pathways. And if we look at the central connections, the vestibular ganglion, or Scarpa's ganglion, sends direct connections to the vestibular nucleus in the brainstem. There are also direct connections through the inferior peduncle to the cerebellum. And then there are second order connections that go up to the oculomotor nuclei, which you can see labeled here. but also to the thalamus and to higher cortical centers. There are also descending connections, which are obviously important for the vestibulospinal tract and vestibulocolic tract. So if we think about kind of categorizing how vestibular function works, it's really a series of different kinds of reflexes that control movement. And the most common one that we analyze is the vestibulo-ocular reflex, which controls eye movements, but also there's the vestibulocolic reflex, which is going to, again, coordinate how the head is situated on the shoulders. And then vestibulospinal reflex, which is going to maintain posture and spinal muscle. So if we look at the vestibular-ocular reflex, in this case, the head is moving with these big arrows here. The head is moving towards the left. And in order for an image to stay focused on the macula in the retina, the eyes have to make an exactly compensating movement in the opposite direction. So if you turn your head to the left, the eyes have to move to the right. Now, it turns out the visual system is really not able to do that. So we cannot maintain a focus of our eyes on a target without the help of the vestibular system, which works much more quickly than the visual system. So when the head moves towards the left, there's a relative movement of fluid inside the inner ear in the semicircular canal, which then triggers that ampulla and stimulates the vestibular nerve, again, connects to the abducens nucleus in the brainstem, as well as the higher third cranial nerve oculomotor nucleus. And the coordinated stimulation and inhibition of those oculomotor nuclei is what's going to lead to contraction of the lateral rectus in this case, and inhibition of the medial rectus and the opposite affecting the left eye. So the way those reflexes work is what allows us to maintain a stable image on our retina with any kind of head movement. And during those changes, if we look at the nystagmus or movement of the eyes, the slow phase of the nystagmus is related to the vestibulo-ocular reflex, and the fast phase, where the eye returns to the position, is really a corrective saccade, which is, again, driven by the oculomotor system. So how does aging affect the vestibular system? It affects it at multiple levels. So in the peripheral system, we know that with aging, there's a loss of vestibular hair cells that begins really at birth. And that happens more rapidly in the ampullae than the maculae, but it's a fairly low rate, but it starts early. There are also changes in the nerve fibers that are innervating all the vestibular organs. It becomes at a somewhat later age, but it becomes more rapid at later ages. There's also a change in the otoconia, which we'll come back to later, but the adhesion of the otoconia through that sort of gelatinous matrix to the macular organs becomes less and less robust with aging and more susceptible to being disrupted by trauma or even just spontaneous decay of those otoconia. The central vestibular nuclei also decay over time. And again, it's a fairly low loss, but there's also an interesting finding that because there's a loss of this peripheral vestibular function with a slower loss of central vestibular nuclei, there's sometimes an underappreciation for how much vestibular loss has happened, because there can be a lot of compensation centrally that can actually mask loss of vestibular function peripherally. And again, we'll kind of come back to that. So this increased compensation in central pathways is kind of a normal part of aging, but it sometimes conceals the underlying changes. With aging, there's also a condition that's been termed presbuvestibulopathy, which basically is a loss of vestibular function that's not to the level we consider a vestibular hypofunction, but it occurs in both ears with the aging process, and it's also associated with loss of function like worsening balance, gait changes, dizziness, and falls. And then we have also a condition that's associated with aging that's multisensory, which I'm sure is, again, very common to you, which is related not only to vestibular dysfunction, but changes in aging, muscle strength and flexibility, proprioceptive changes in peripheral neuropathy and so forth, and how those things will also affect the vestibular system. So one of the keys to arriving at a diagnosis for different types of vestibular disorders really is the history, and it's the timing and the triggers of what causes the symptoms. So if we're thinking about very short-lasting conditions on the order of seconds to minutes, by far the most common condition triggering that type of dizziness that's triggered by position changes is BPPV, but there can also be some dizziness that's triggered by head movement on the shoulders. So as opposed to being effects of gravity, it's effective position changes of the head relative to the rest of the body. So with head turning, and that can be triggered by cervical spine disease. There can also be short-lasting attacks of dizziness triggered by sound or pressure changes. And the most common sort of diagnosis for that is probably a superior canal dehiscence, which we'll talk about a little bit. And then less commonly a fistula, which causes pressure changes again to be transmitted to the inner ear. In intermediate duration, sort of on the order of minutes to hours, the most common diagnosis in most cases is vestibular migraine. And less commonly, but seen frequently in our clinic, is Meniere's disease. And really, as we'll come back to, the distinction between these two disorders is becoming somewhat murky. They may be closely related, but the real sort of distinction is that there's a progressive hearing loss in Meniere's disease that we don't typically see in vestibular migraine. Now, in the more chronic nature of days to weeks, that can be a sequela of vestibular neuritis or vestibular inflammatory nerve disorder, from labyrinthitis, where it also affects hearing, or again, migraine. There can also be effects related to trauma and concussive disorders, again, chronic fistulas or cervicogenic dizziness, again, from compressive phenomena, cerebrovascular disease, demyelinating disease like multiple sclerosis, or effects of medications or interactions of multiple medications. And in a longer time period where things have persisted for multiple months, we have two diagnoses that are fairly recently described in the last decade or so. One has had several different names, but the current name is persistent postural perceptual dizziness. And it may be triggered by any number of these different disorders, but it leads to a more chronic sense of imbalance or dizziness that can persist for many months. And then mal de débarquement, which is a similar description that patients often give, but it's typically triggered by a very specific event, where, such as being on a boat or a train or something like that, or where they have a sense of disorientation that persists, but was triggered by a specific environmental trigger. So this is sort of a flow sheet that analyzes the way that I think is very useful to think about diagnosing different disorders of dizziness and vertigo. So the one question we sort of talked about earlier is, are the symptoms episodic or continuous? And is that episodic dizziness, is it triggered or is it just spontaneous? So for triggered dizziness, as we looked at when we looking at the sort of the etiologies earlier, by far the most common etiology is benign paroxysmal positional vertigo. And there's a very definitive way to diagnose that using the Dix-Hallpike mover that I'll review. If that test is positive, they basically have that diagnosis. Now, if the Dix-Hallpike test is negative, then there are other things that can potentially cause positionally triggered dizziness. And the most common ones are going to be things related to cerebrovascular perfusion, whether that's actually orthostatic hypotension in a sort of a strict definition, or if there are changes in perfusion related to position changes, or could be exertion or cardiovascular output for other reasons. In spontaneous episodic events, we have, as I mentioned, when that is associated with a hearing loss, the most common diagnosis is Meniere's disease. What's much more common on a population basis is actually migraine headache. And what's clear is that even though we used to think of migraines as always consisting of headaches, it's more clear that many individuals who may have had migraines in the past often will transition the way they experience migraines where they only experience dizziness. So very frequently, these individuals have no headaches at all, but they can have episodes of vertigo, which can persist sometimes for days. So by far the most common diagnosis that we see in our clinic for that kind of array of symptoms. And then obviously panic attacks, anxiety, and so forth can also trigger very similar dizziness symptoms. When the symptoms are more continuous, obviously in the shorter term, the things we're concerned about, if you have immediate onset of severe vestibular symptoms, is this a stroke or a TIA, or is this an acute vestibular nerve inflammatory condition like vestibular neuritis? And really the key to that diagnosis is what's called the HINTS test or HINTS examination. I'm going to go over that in detail because that's kind of a critical part of the exam. And depending on the results of that test, it's a fairly robust way to distinguish between vestibular neuritis and a central neurologic event. So basically, if you think about it, in terms of the history, there are really only a couple critical things. There's the history and a couple parts of the physical exam where you can really make a lot of the diagnoses. So if you remember these two main components of the exam and getting a careful history, we can usually arrive at a definitive plan for the patient and also give them an idea of what the risk is if they're having something like a stroke. So we're going to focus on the key exams that I mentioned there. So the Dix-Hallpike test, probably all familiar with, but this I think is a kind of a helpful diagram that I found. And if you have an individual, in this case, they're turning their head to the left and their head is inclined back about 20 degrees. They're sitting up. Usually I have them do this sitting on the exam table and then just lay back. You want to make sure that their head is actually sort of hyperextended. I usually put my hand underneath the back of their head and one hand under their back so they feel that they're supported and not at risk for falling or that you're going to injure their neck. And then what's happening in the case of BPPV, what's happening is the otoconia are dislodged into this posterior semicircular canal. And if you remember the diagram from before, the utricle is sitting up here. And it makes sense why this would happen and why the posterior canal would be most commonly affected, because if you think about it, just by gravity, if those crystals fall off, they're going to tend to drift in the dependent part of the inner ear, which is the posterior canal. So what happens when they move their head, and this would be the same trigger for BPPV, is those little crystals slosh around. So when they move inside this canal, they trigger a fluid movement, which then deflects that cupula that I showed you earlier and triggers the vestibular nerve. So whenever there's a conflict between our perception of the environment and a sort of a aberrant triggering of the vestibular nerve, that's vertigo. That's the sense of spinning. So that's why the head movement triggers the sense of spinning. So in the Dix-Hallpike maneuver, you can see that these crystals, again, they drop into the dependent part of the canal, trigger that fluid movement, and stimulate the vestibular nerve. Now, depending on which canal is involved, it's going to cause different eye movements. And really the diagnosis to decide which of the 6 semicircular canals is involved is based on several of these therapeutic or diagnostic maneuvers. So in this case, we're thinking about the left ear being involved in the posterior canal. If they're looking straight ahead without fixation, the eyes have a very typical movement where they're moving vertically and clockwise. So in the left ear, it's a clockwise movement. And so it's a torsional movement. So there's a twisting to the eye, as well as an upwise movement. And that makes sense because the posterior canal is oriented vertically, but it's not anterior posterior, it's deflected, angled 45 degrees to the side. So if you see a purely vertical or purely vertical upbeating or downbeating nystagmus, that's not caused by one of the vertical semicircular canals. It has to be a central phenomenon because the canals are not oriented in that direction. Now with BPPV in this individual, if they look to the right, the nystagmus is going to become more vertical, whereas if they look to the left, it's going to become more torsional. So this is another maneuver you can do when you're doing the Dix-Hallpike to see if the nystagmus changes in this way when they look either medially or to their left or to the right. So again, looking towards the affected ear, it becomes more torsional. Now the HINTS test, which stands for the head impulse test and the negative test of Skew, has become more popular over about the last, probably 5 to 10 years, I guess, and really mostly due to the work of David Newman-Toker. And it's been found to be more sensitive even than an MRI in detecting an acute central vestibular syndrome. So it's performed really only in acutely symptomatic patients. So really the distinction is try to identify somebody who has BPPV versus a posterior circulation stroke. That's really what its main utility is. The head impulse test, though, is a commonly used test to just evaluate the vestibulo-ocular reflex. And with that test, the head is moved about 30 degrees to either side and then quickly moved back to the midline while they're looking at usually at your nose, fixating on your nose. In the normal situation, the eyes will remain fixed on your nose as you snap the head back to the midline. Whereas in acute vestibular injury, the eyes will delay and there'll be a catch-up saccade back to your nose, the target. And that's because there's a loss of the vestibular input that stabilizes the macula on your nose. So in this case, in the HINTS test, the normal exam means that there is not a corrective saccade. And that's what we would expect in a central vestibular injury. The other deciding factor is actually the type of nystagmus. And so the direction of the fast phase, which again is the corrective phase. So in a peripheral lesion, the direction is going to beat towards the weaker ear, the damaged ear. So again, that's the corrective saccade back towards the damaged ear. And no matter which way the patient looks, so if they look to the left or the right, the direction of the nystagmus is going to stay the same because it's caused by an irritative or hypofunctional lesion in the inner ear. Whereas in a central vestibular lesion, they might, for example, look one direction, the nystagmus will beat one direction or beat up, and then they'll look the other direction, it'll beat the opposite direction. So that changing direction of nystagmus is something that we would expect to see only with a central lesion. The test of Skew is another test that people may not be quite as familiar with. And the test for that is the alternate uncover test. And I can kind of show you, I think probably you can see on my video. But in the normal situation, we have the patient look ahead and look a little bit to the side, and you cover one of their eyes with a white piece of paper. And as you pull the paper away or shift it to the other eye, in the normal situation, the eyes should be horizontally matched. I'm trying to figure out how to look at my camera here. They should be horizontally matched. So if you uncover the eye and one of them shifts, then that shifting of the eye, so they're no longer aligned in the horizontal plane, is abnormal. And so again, that would be more suggestive of a central lesion. So we think about the goals of treatment of any type of vestibular disorder. Obviously, the initial plan is to treat their acute symptoms symptomatically. And really the goal of that is to treat some of the vestibular stimulation, but also some of the autonomic responses. In patients that have more chronic or recurrent symptoms, ideally we like to restore that sort of steady state situation where they're not having chronic symptoms and try to prevent recurrence. And in some cases that we'll talk about, there may need to be some type of an intervention. If the labyrinth itself is sick or constantly fluctuating, then the central nervous system can't compensate. And really the treatment is to try to stabilize that labyrinth or potentially ablate it so that it's no longer causing a variable input. So we think about pharmacologic therapies. There are multiple classes of medications, and most of them are fairly non-specific in the way they're used. And unfortunately, also have many side effects. And so there are different ways that they can work. And there are vestibular suppressants, which can be very effective for helping with vertigo and nausea, working through the central vestibular nuclei and the autonomic centers. There are also antiemetics, which can be helpful, both in the central nervous system centers, but also in the peripheral enteric system in terms of stabilizing some of the GI side effects that people have with severe vertigo symptoms. And then there are also medications that are related to treatment of migraine, which again is a very common disorder that we see. And there are multiple families of medications that can be used in migraine prophylaxis. It's not that clear that in acute vertigo that migraine treatment medications are that helpful, but there's some information that suggests that's true. So when we're choosing drugs in the acute situation, which would primarily be something like labyrinthitis, really what we want to use are things that actually allow some degree of sedation and allow patients to recover and return to normal activity. So common medications we might use are promethazine and lorazepam, and especially if they're not able to take oral intake. Whereas with chronic recurrent attacks, we want to have less sedation so patients can function and be able to do other things. And less sedating medications like meclizine or diazepam are frequently used. There are a number of studies that show meclizine, which is typically not habit forming, is just as effective as diazepam. So I rarely use any benzodiazepines, even in Meniere's patients. But it is important to note that medications really are never indicated for individuals with BPPV or with bilateral vestibular hypofunction. And in fact, in these individuals, especially with bilateral vestibular hypofunction, which I showed you is much more common in the elderly, they can actually make the symptoms worse. So one of the things that you really need to be careful with is in people with this type of disorder is that there are not additional medications that are compounding the negative effects of their underlying vestibular disorder with medications for blood pressure, for example, or other kinds of neuroacting medications that are common suppressants. And so the goal, of course, is to minimize suppression and try to get people back to recover. So now we're going to look at a couple different types of disorders and how they're treated. So with BPPV, which I mentioned before, the treatment really is to start with identifying which canal is involved. And this shows the most commonly involved canal, the posterior semicircular canal. But there can also be involvement of the horizontal semicircular canal and the anterior semicircular canal. I kind of listed out here the description of how the nystagmus is different. Most commonly, you're going to see the posterior canal, but it is helpful to know how to test for the horizontal canal. And typically for this, you'll have the patient lay flat and they won't feel dizzy just laying flat, but if they turn the head to the right or the left, then they'll have a nystagmus. And depending on which ear is involved, it'll be either geotropic, meaning that it's beating towards the ground, but it will change position looking the other way, or it'll be beating up. So apogeotropic, beating away from the ground, and it will also change position when they turn their head. So again, and the stronger position, where they have the strongest nystagmus, is the side which is usually offending horizontal canal. Anterior canal, BPPV, fairly rare, and there's this torsional downbeating nystagmus typically. So the Epley maneuver is the standard, most commonly used maneuver. It's been around for about 30 years or so now. Very, very effective if used properly. And if it's used repeatedly, it's even more effective. So this shows somebody who has an affected right posterior semicircular canal. It shows where the debris is starting off here in the posterior canal here at the bottom of the canal. And as they go through these successive positions, you can follow the debris as it moves through the semicircular canal back to where it drops back into the vestibule, where it's not going to trigger movement of fluid inside the canal and trigger the cupula again. So the first movement is to turn their head in the same position that would have been the most affected Epley maneuver. After their head is down, usually wait between 10 and 30 seconds until all the symptoms have passed. Turn their head rapidly towards the opposite direction. And again, their neck extension is important here, so about 20 degrees. And then they roll over onto their shoulder and their hip, so their face is pointing about 45 degrees towards the ground. And that's what's going to drop these particles back into the vestibule. So a couple things you can, and then after they've done this position, they basically, I tell them to kind of tuck their chin to their shoulder and then support them as they sit back up sideways, and then they can relax. And depending on if there's how symptomatic they were during this, the first round, I'll do another round the same way. And at each step, you want to verify the type of nystagmus they have, like I showed you in the previous image. One thing to know is that sometimes when you're doing this maneuver, you can see that the particles can move, but as they move, they can drop into a different canal. So if you're not following this degree of turning the head, for example, you can imagine that if they sit back up, sometimes the particles can actually drop into a different canal, whether it's the anterior canal or the horizontal canal, in which case you might need to do a different maneuver. So I'm not going to go through this in detail, but there are different maneuvers for the other types of BPPV affecting the other canals that have a similar efficacy, but actually they don't have the similar efficacy, so they're not as effective. But in fact, with a horizontal canal, it's much more likely to resolve spontaneously. And again, that relates back to the anatomy, where again, the posterior canal is the most dependent, whereas any debris in the anterior canal or the superior canal or the horizontal canal is going to tend to spontaneously more likely be liberated from the canal. So they tend to resolve more spontaneous. Now, there is an increased frequency of BPPV in the elderly. And as I mentioned earlier, that's probably related to how stable the otoconia are and the turnover susceptibility to dislodgement by trauma. There are a number of recent studies that are interesting that looked at the recurrence of BPPV. So it's more commonly recurring in the elderly, but also in certain individuals. And there is some association with low levels of vitamin D. And there's a little bit of evidence suggesting that at least in individuals that have low levels of vitamin D, that if they are supplemented with vitamin D and calcium, that they can decrease the recurrence rate. So this is looking at individuals that either got vitamin D and calcium and were just observed, or if they had supplementation, and this is the recurrence rate of BPPV over about a year period. So it's not like it completely resolved it, but it certainly seemed to help. And similar findings were found in a number of other studies. So typically in my patients, if they have recurrence of BPPV, especially in the Northwest where many people are vitamin D deficient, I usually recommend doing 1,000 units of vitamin D and 500 twice a day of calcium. Now, is BPPV always benign? It's also interesting to see that when it's been looked at carefully, that individuals that are seen in the emergency room for BPPV actually have a higher incidence of having a stroke during the following years. So the etiology of this is not clear, but it's possible that this may be related to changes in blood flow to the inner ear. And maybe the reason these individuals are getting BPPV is there's sort of a subclinical effect on the health of the inner ear that predisposes to dislodgement of those otoconia. So not really known at this point, but kind of an interesting finding. Meniere's disease I mentioned, so it's kind of the one which I think was a more popular diagnosis in the past, but we found more recently that many of these individuals actually suffer from migraine. So definite Meniere's disease is defined as having greater than 2 episodes of vertigo from 20 minutes to 12 hours. They have to have fluctuating hearing loss, and we have to document it with an audiogram. They often will have tinnitus or oral fullness, kind of a pressure feeling in their ear. And sometimes they can have the hearing loss before they actually start experiencing the vertigo. So they may have a progressive change in hearing in one ear, and then a year or two later, they may develop some of the vertigo symptoms. So the pathology of that is a dilation of the intralymphatic spaces. We don't really know why this occurs, but this change in the intralymphatic spaces is felt to be what eventually triggers a breakdown in the separation between the paralymphatic and intralymphatic spaces that causes the symptoms of vertigo. There's a little bit of progress with this, and we're doing some of this here at the university, looking at using MRI imaging to look at the dilation of the intralymphatic spaces. And this just to kind of show you how this looks. Basically, in this case, we're looking at the size of the intralymphatic space, and this is in the vestibule, which normally would be very small, so you'd hardly be able to see it. And the way the images are processed are to show the intralymphatic space in black. So again, in this case, normally this would be the scale of media, would be very, very small. And so in this case, using this type of a procedure with MRI, we can really actually visualize the dilation of that space. The therapy for Meniere's disease is primarily medical, so the vast majority are managed medically. We recommend a low salt diet, attention to triggers that are commonly caffeine reduction, nicotine cessation. A lot of the dietary triggers we recommend with migraines are the same we recommend for Meniere's. We recommend are the same we use for migraine. So part of the challenge with Meniere's disease in assessing outcomes is that there's a natural stability over time that 60–80% of people eventually stabilize without doing anything. So it's really complicated, some of the research and finding out the long-term prognosis with individuals that are treated with different interventions. As I mentioned, there's a large overlap between Meniere's disease and migraine. And many of the migraine symptoms that are common are the sense of vertigo or unsteadiness, dizziness that can be either severe and disabling or just kind of mild and disorienting. They can have ringing in their ears. They can have fluctuating hearing loss and fullness, in addition to the more typical migraine symptoms that we think about. Whereas exclusive to vestibular migraine would probably be the photophobia and phonophobia that we more typically see with migraine. And then in Meniere's disease, we have a progressive hearing loss. And what's important to remember is that migraine is much more common than Meniere's disease. So for vestibular migraine, the definition is 5 episodes of these vestibular symptoms, again, lasting up to about 3 days, and a history of either current migraines or previous migraine. And in many individuals, especially in the elderly, they may not have had migraine headaches recently, but they often had migraines when they were younger. And again, remember that the headache symptoms and the vertigo can be independent. So migraine, extremely common in women overall, about 18%, whereas 6% of men. Whereas Meniere's disease, very small percentage of the population. So migraines are about 20 times as common as Meniere's disease. So always remember that when you're trying to figure out what's going on with your patients. And in terms of how migraine and Meniere's are related, again, there might be a connection between how these affect the inner ear. And so in one of the models for migraine, where there's a sort of a central electrical disturbance that causes changes in brain excitability in areas that are affecting the vestibular centers, others would suggest, and this is probably the more dominant model now with the understanding of the trigeminal neurovascular system, is there a release of peptides like CGRP that may be triggering events both relating to headache, but also relating to changes in the inner ear and some of the dizziness symptoms. So the key for vestibular migraine is ask the questions, try to really prod the history about migraines in the past, what the precipitating factors are, and what sort of dietary changes and things they might be able to institute. So typically for these patients, we recommend lifestyle changes related to diet, supplementation with magnesium and vitamin B2 is shown to be effective. And then in most cases, we work with neurology to work on preventive medications if it looks like that's the main diagnosis. So surgical management is rarely necessary for most patients with vertigo or dizziness. So probably less than 10% of patients end up needing to have surgery. And really, it ends up being the patients that have failed the things we talked about. So for fluctuating unilateral vestibular function like BPPV, that's usually treated with physical therapy. Superior canal distance, I'm going to talk about briefly because that's one where surgery is the primary treatment if people are affected. Meniere's disease, rarely treated by surgery now. We often treat it, if it's not successful symptomatically, is with injection of gentamicin through the tympanic membrane. And really the goal of any surgical treatment is to try to obtain an ear that's stable with remaining vestibular function, if possible, but if necessary, sometimes we have to ablate the affected ear to allow a situation that will allow central compensation. So superior canal syndrome was the first described back in 1998 by Lloyd Minor. And really it's a fairly distinctive constellation of symptoms. So they have vertigo with loud noises. For example, slamming doors is a common one. Sneezing will cause them to become dizzy, lifting something heavy, blowing their nose. They'll feel a sense of shifting or movement when they do those things. They may have a more chronic sense of constant disequilibrium, and they often have an elevated sensation of hearing to bone conduction. So they may feel like they hear their heartbeat, they feel their heels hitting the ground, they may feel their eyes moving. And on audiometric testing, they have a conductive hearing loss, but they have normal acoustic reflexes, which is something we use to distinguish this from otosclerosis. And then there's some laboratory testing that we use as well that I'll come back to. So the way this syndrome happens is there's a thinning of bone over the superior semicircular canal. So as opposed to being completely encased in bone, there's a dehiscence of the bone that I'll show you in the next slide. And when there's any pressure change inside the inner ear, that causes a shunting of pressure out through this window. So we call this a third window phenomenon, and leads to an abnormal movement of fluid inside the inner ear. That movement of fluid is going to trigger movement, in this case, of the superior semicircular canal, and that will trigger the movement of the eyes in the direction we would expect based on stimulation of the superior canal. So this shows a CT scan showing where there's absent bone over the top of the superior canal. And this is in this plane here. So this is the superior canal here, and we're looking right at this area here where the top of the canal doesn't have any bone. So in talking about ablative procedures, really the rationale is to try to trade what's a sick, unstable ear, like in the case of Meniere's disease that's not responding to more conservative treatments, or for example, in some cases, even a vestibular schwannoma, or somebody who's had labyrinthitis or vestibular neuronitis and have an unstable fluctuating function in their residual ear, then we might want to trade that for a non-functional ear. And really it's relying on central compensation. So if an individual has a peripheral vestibular loss and they don't have a normal central compensation mechanism, we don't want to do a vestibular ablative procedure. And I think I'm going to skip over these for time. So we work very closely with physical therapy in all the types of conditions that I've talked about. And in the more sort of typical situation, we might be asking them to help with patients to develop compensation strategies and compensation for something like an acute vestibular neuritis or following some type of ablative surgery, or in sort of honing their compensation, but also substitution strategies for bilateral vestibular hypofunction. In unstable lesions like BPPV, we often utilize them for the therapeutic Epley maneuver, especially if they're atypical canals, or if they've had recurrent attacks over many years. It's helpful for them to have the input of a vestibular therapist. But physical therapy is also helpful in patients with Meniere's disease and migraine, because they may be able to help with some of the trigger counseling, especially with migraine. They may have some muscle tension triggers and things like that physical therapists are very adept at doing training. So they use a number of modalities in their therapy. A good resource is to look on the neurologic physical therapy site. So if you go through the sort of exam that I mentioned in the history, and you still feel like you're completely lost in terms of what is causing the symptoms of the patient, then there is a role for doing some specific testing in the balance laboratory. And we have a balance laboratory at the University of Washington, but also at the VA and at Children's Hospital, with pretty similar a range of testing we're able to do related to vestibular function. So again, if you've gone through your various types of treatment that we outlined above, and you end up with somebody who's still, you don't have a clear diagnosis, then it's helpful to get some testing. And the testing that's helpful relates to identifying the different components of the peripheral and central vestibular system and how they might be causing the persistent symptoms. So these are some of the testing that we use. So in ocular motor tests, we can look at the function of the ocular motor system with saccades, smooth pursuit, optical kinetic, reflex testing, gaze testing. These are all done with video goggles and recorded, so we can get a much higher resolution analysis to see if there's some subtle abnormalities that might pinpoint a central lesion as an example. Looking at the peripheral function, vestibular evoked myogenic potential testing is a good way to look at some of the otolithic function. Subjective visual vertical and subjective visual horizontal tests, again, look at otolithic function. Additional tests, the head impulse test like we used in the HINTS test, but also the chair test and caloric testing help us understand the semicircular canals. And then we have the audiogram to look at another aspect of the labyrinth. Computerized dynamic platform posturography really looks at how all these systems work together. And it's a way we can use to see how well they've used their compensation strategies and whether there might be any kind of a functional component as well. So just to kind of review, there's a number of different conditions that can cause dizziness and imbalance in the elderly. And I've kind of summarized some of them here in terms of the how common they are. But I think what's important to remember is that, again, if you're struggling with the things that we talked about, that there always are other avenues to do some additional testing and clarify what's going on. And it's always possible that it is the ear that's causing the symptoms. And I'd be happy to take any questions.
Cliff, Wayne McCormick here. We often tell our older folks who have vertigo or have been diagnosed with Meniere's disease to hydrate with, fluids that have some electrolytes in them. Does that actually help, or is that neither here nor there?
I think there's probably no real data for it, specifically for Meniere's disease, because the kind of the confusing part is, of course, we want low sodium, but if you have older individuals that may be on antihypertensives and maybe borderline, orthostatic in different situations also, then, do you want to hydrate them because they're orthostatic, or do you want to give them sodium that might make Meniere's worse? So I think we don't have really good data on that. Even the data on salt restriction for Meniere's disease is not very strong. So I don't typically, I always recommend it because it's generally healthy for you anyway. But for Meniere's disease, I don't feel that strongly that sodium restriction is really going to cure anybody. But I think hydration, as you were saying, is probably a more common problem than Meniere's disease by far.
I have a quick question. Sometimes the 60-year-old son is asking, is he going to get the condition of his 80-year-old father? How many of these have a genetic component?
So I think certainly for migraine, there's a strong genetic component. For Meniere's disease, it doesn't. There is a very small subset that there may be a genetic component, but I would say in general, no. Part of the challenge we have historically with looking at patients that were diagnosed with Meniere's disease is that even 5 to 10 years ago, many patients who actually had migraine were diagnosed with Meniere's disease, and they may have already had surgery for Meniere's disease. So it becomes very complicated to kind of deconstruct what they originally had when 20 years later, we're trying to figure out what they had, and they've already had a bunch of procedures, and which may have caused further damage to the ear. So I would say genetics is not a huge part of it. But there certainly are a number of vestibular disorders, like in terms of vestibular hypofunction, just like there's conditions that lead to progressive hearing loss, there clearly are some kinds of genetic conditions that lead to progressive vestibular loss. So those things probably are genetic to some extent.
Dr. Hume, would you mind speaking a little bit more about the ablation procedure and what the success rate is, and how well it's tolerated by older adults?
Sure. So the most common situation that's used for would be usually in a Meniere's patient who has basically, if you can imagine that labyrinth that's affected is sick, And by that, I mean that it's fluctuating. So it doesn't allow central compensation. So sometimes we can inject a steroid, which will cause, some anti-inflammatory effect and may help with stabilization of that ear. It's not clear how effective that is. It's probably partially effective. What has been shown to be effective is if that ear is fluctuating and is the source of the dizziness. So we do a lot of testing before considering an ablative procedure. But if all the testing is consistent with the fluctuating labyrinthine function, then the ablative procedure is basically typically now done in the office, and we inject gentamicin, the antibiotic, but it's actually toxic specifically especially to the vestibular hair cells. And so the patients, it's done in the clinic, and they don't normally have that much side effect from the initial treatment. They're sent home, they go home the same day. And usually what they have is some very mild worsening of their dizziness symptoms for several days. And then we usually have them participate in physical therapy because we're assuming that they've lost function and now they need some basically central compensation strategies and training. That can be incredibly effective. So if patients are really disabled by recurrent Meniere's attacks, I've had many patients that are not able to work. They're afraid to drive because they'll have a Meniere's attack. They're driving down the road, or they're at work doing some high risk type of procedures. And the type of ablation I'm talking about, which is the chemical labyrinthectomy with gentamicin, can essentially completely eliminate those attacks. Now, the problem is that we're eliminating function, and we're not eliminating all abnormal function. We're also eliminating normal function in that ear. We try not to do it completely, so we don't blast it with a full dose of the medication. We typically try a low dose initially, but it does mean they're actually losing overall balance function from that ear. So I usually advise patients that even though the goal is to eliminate the vertigo attacks, it's possible their baseline sense of balance might be worse, at least initially. It might improve with physical therapy, but that's something they really need to be aware of. So again, it's directed towards the episodic attacks, not their baseline sort of unsteadiness, because that might actually get worse. So they really need to understand what that role is. But it's also used occasionally. For example, if you had a patient with a vestibular schwannoma who was maybe not a good surgical candidate, but was having some vertigo attacks, we might consider doing this treatment because obviously it's an office procedure as opposed to a craniotomy. So and that's another situation where I use it occasionally.
Thank you.
Thank you so very much for this presentation and for answering our questions. We really.
Oh, you're welcome. Thanks for inviting me. And I did put on the last slide there a couple of useful things. If you're kind of confused about eye movements, or you want to just, if you're fascinated with eye movements, there's an app that was made. It's by Dr. Hamagi's lab by Hamish McDougall, and it's on the App Store there. It's called AVOR, and it's really awesome. You can basically put in whatever sort of a central or peripheral vestibular lesion you want, and it will show you what the eye movements will look like when you do different manipulations. So it's really a nice way to visualize if you're trying to think about what would that look like. Even if you see a patient in clinic and say, well, is that BPPV? Should that really do that? You can pop this up on your phone and look and see, hey, wait a minute, that doesn't make sense. It doesn't fit with what I'm thinking. And the other one is through the Barani Society is the International Classification of Vestibular Disorders. And really, it kind of just clarifies in a lot more exhausting detail what some of the kind of definitions are of these various disorders, because that can be very helpful when you're trying to, decide what the next step is. So, and then for patients, I almost always refer them to the Vestibular Disorders Association. They have an awesome website with a lot of patient education material. They have references to vestibular therapists and to surgeons, all kinds of people that are interested in people with dizziness disorders. So that's an awesome resource. And I would definitely send your patients there.
Great, those are fantastic. Thank you. I'm looking forward to using that app in clinic.
Yeah, it's fun.
So fill out evaluations, everyone. There's a link in the chat and the QR code for those attending the division meeting. It's a separate link. So look in your Outlook calendar and click on that Zoom link to head over to the division meeting. Thanks, everyone. Have a good weekend.
Thank you.
Thank you. Bye-bye.